I'm Stephen Ginsburg. I'm a GP and a board member of Sydney North Health Network, and I'd like to welcome everyone from the Mental Health Professionals Network and from Sydney North Health Network. And we're looking forward to a very exciting presentation. So I'm just going to introduce who's helped set all this up. Judy is our Zoom wizard tonight. She's the education coordinator at Sydney North Health Network. Craig Parsons is Mental Health, Drug and Alcohol Commissioning Manager at Sydney North as well. Good evening, Craig. And Michelle Ferris, we need to thank Michelle because she heard Anne Warren presenting and has arranged for this evening's webinar. And Michelle's dementia consultant at CCMB, Community Care Northern Beaches. So I'd like to start by paying our respects to elders past, present and emerging, and acknowledging that we meet today wherever we are on Aboriginal land, always was and always will be, and acknowledging the elders of all the communities in our area. And First Nations cultures have survived on this continent for over 60,000 years, and prior to 1788, people were in better health than by most of today's indicators. It's a sad realization that suicide was believed to have been a rare occurrence amongst Aboriginal and Torres Strait Islander people in Australia in pre-colonial times. Indeed, there's no word in Yolngu language to describe the phenomenon of suicide. So Anne is going to bring us up to date with what's happening here in Australia now. So without further ado, I think I will now find my introduction to Anne. Here we go, I've got it. So, hello Anne. Anne Wand is a consultation liaison and old age psychiatrist working in older persons' mental health at Concord Hospital. Dr. Wand is a conjoint associate professor at the University of Sydney and a conjoint senior lecturer at the University of New South Wales. And in her PhD, she studied self-harm in the very old. Dr. Wand is a clinician researcher who has over 65 peer-reviewed publications in the areas of late life self-harm, delirium, BPSD, decision-making capacity, consultation liaison psychiatry, and cultural aspects of mental health assessments of older people. And in our little chat before we went live, Anne does home visits. one of the great champions of home visiting geriatricians and older age psychiatrists. So Anne, over to you. Thank you for coming this evening.
Well, thank you very much for that warm welcome, Stephen, and to the Mental Health Professionals Network for inviting me to give this talk. I'm just going to attempt to share my screen again to get this moving. Okay, can I just check, Judy, are we all good with that? Is that visible?
That's perfect, thank you.
Okay, I'll just move that out of the way. All right, so there's been much talk in the media recently about suicide, self-harm, increase in mental health problems in the general population during COVID, but relatively less discourse about the impact on older adults, which is my focus today. Let me see if I can change slides. Okay, not that button. Excuse me while here we are. Okay. So much of this talk overlaps with one that I gave in a webinar for the Psychogeriatric Nurses Association earlier this year. And that webinar really came from a paper that we were invited to write by the International Psychogeriatrics Association. And myself and some international colleagues wrote a paper about how COVID-19 might be expected to impact suicide in older adults. Now, this paper is freely available on the IPA website. You don't need any logins or anything. And so I'd invite you to go and have a look at the paper if you would like more detail or to check references, but also the particular edition, which is published online and is open access, has a range of topics relevant to COVID-19 and older adults from many different countries, many different perspectives, and different focus in terms of mental illness. So please do have a look, it's really useful. And again, thank you to my co-authors in China, Italy, and Hong Kong and Australia for their collaboration on this work. More recently, Professor Carmel Pisa and I wrote a short piece in the Medical Journal of Australia, really to highlight, particularly to GPs and primary health professionals that tend to look at the MJA, to think about suicide and COVID-19 and how the risk factors for suicide in older people might be exacerbated in the pandemic. This paper too is also freely available on the MJA website on the first view if you're interested. So today I'm going to be talking about suicidal behaviours and the pandemic, and look at how suicide rates in older adults might be affected by COVID-19 and some of the international challenges to suicide prevention during the pandemic, using a few sample countries and regions to exemplify different perspectives. And finally, looking at potential solutions, and these are predominantly Australian focused. As Judy mentioned at the end, if you do have any questions, save them up or pop them in the chat box and she'll collate them and I'll address them at the end. So it's too soon to tell whether there's been an increase in suicide rates in association with COVID-19, but there have certainly been numerous case reports in the media across the age span. For example, in Germany, there was a death by suicide of a 55-year-old state finance minister, which was attributed to his despair and being overwhelmed by concerns at how he would manage the financial impact of coronavirus. At the other end of the spectrum, there was a teenager in the UK whose story was written up in, I think it was The Guardian actually. She died again by suicide, and she left messages on social media saying that deaths from suicide would be greater than those from the virus itself. And she highlighted her difficulty coping with isolation and uncertainty. So although these two early cases in the media were younger cases, they highlight some of the factors that contribute to suicide, such as economic hardship, uncertainty, and isolation. Of course, we also heard about some very tragic deaths of healthcare professionals, and I understand that most of the audience works as a healthcare professional. In Italy, Daniela Trezzi, a 34-year-old nurse who worked in the COVID-19 ICU in an area near Milan, died by suicide. She discovered that she'd contracted coronavirus and was so distraught at the possibility that she may have inadvertently spread the virus to her patients and family, and combined with being exhausted and overworked, took her life. The Italian National Federation of Nurses said in a brief statement how tragic this was, and that the heavy fear and stress of healthcare professionals in potentially affecting others was devastating. Another case across the world in New York, Dr. Lorna Breen, who was the director of an emergency department, also took her life during the pandemic. She didn't have coronavirus, but her sister spoke of the dreadful stress that the pandemic had on emergency staff, that she described her sister talking about the situation like Armageddon, that there were sick people everywhere, not enough oxygen, not enough room, people hanging out of the waiting rooms, staff doing 12-hour shifts and in fact feeling guilty going home at the end of those 12 hours because there was all this unmet need and people that needed care, and just feeling that she couldn't help enough, that those things had contributed to her ending her life. Tragically, this was the first report I came across of an older person ending their life by suicide, which was attributed to coronavirus. So this gentleman, Dennis Ward, was described by his grandson as a guy that loved betting on the horses and entertaining people around him, and the huge shock to his family that he had ended his life. Professor Rory O'Connor, who's an expert in the UK, who was assessing the coronavirus outbreak's psychological impact in the UK, particularly highlighted that people who feel trapped and lonely during the lockdown need to be identified quickly and targeted for the help that they might need. More recently, there are also reports of older people in New York, for example, a man who had been diagnosed with cancer, who hanged himself actually within the hospital after testing positive to coronavirus. So these tragic cases really highlight how real this situation is and that it does impact older people. Professor Louise Aronson, who's a professor of medicine at University of California in San Francisco, wrote a really moving and quite distressing piece in the New York Times recently, talking particularly about nursing home residents. So she spoke of seeing clinically a growing number of suicide attempts by older adults in San Francisco. And she highlighted the lack of human contact, not having meaningful activity or a sense of purpose, and losing hope that the coronavirus pandemic would actually improve in a time frame relevant to older adults. And I think that last point is very interesting and really hasn't been discussed. You know, we all talk about, well, maybe next year it'll be okay, or maybe in 6 months. But for people who may be advanced in age and have life-limiting illnesses, this may not go away within their lifespan, and they may be looking at the isolation being a reality of the rest of their lives. She gave some harrowing stories of what the situation was like in nursing homes in New York. Stories of people dying of neglect, of starving to death, people seeming defeated, lying in bed with no hope of reprieve, people with dementia really fighting to understand these severe restrictions that don't make any sense. And she suggested that there was excessive sedation going on for what was termed as behavioural issues. Group meals had stopped, indoor and outdoor activities, visitors, resulting in much more isolation, higher rates of depressive symptoms, suicidal thoughts and agitation in people with dementia. But also observed in people with dementia, much more agitation. And along with that, people that were really doing nothing and had no stimulation becoming weaker, more muscle atrophy and falls. So it really highlights some of the complexity of issues. So these are the particular risk factors for suicide that we know about that I'm going to talk in more detail about today. So social isolation, disconnection, burden and ageism, impacts on mental illness, how coronavirus might impact suicide in people with dementia, and economic impact. So starting off with social isolation and quarantine, and this is certainly the one that we hear most about. There's been strenuous advice for older people to stay home. And we know even people living in communal living, senior housing communities feel lonely at the best of times, let alone when they're now told to stay in their unit and not go out. We know that living alone, loneliness and social isolation are potent risk factors for suicide in late life. And these effects can be compounded for people with pre-existing mental illness who may already have quite narrow social networks and limited opportunity for social contact. We know from the SARS outbreak that quarantine is associated with psychological distress, especially when it's enforced, that is, people don't have a choice, and in particular conditions. So during the SARS outbreak, for example, in Taipei, there was a quarantine hospital in Taipei, and there were very poor mental health outcomes which were associated with quarantine, particularly those of a very long duration and associated with frustration, boredom, with the people in quarantine not having enough information or enough supplies for meeting their basic needs, and the fear of infection, that is contracting the virus, which at that time was SARS. So all of those things certainly impact older people. And there are other unintended consequences of isolation and quarantine. And that's things like the social distancing leading to physical deconditioning, increasing rates of pain and disability, which again are also potent risk factors for suicide in late life. We know that many people use exercise as an effective treatment for depression. There's plenty of evidence to support that. And that option is off the table now for many older people with the advice to stay home. The disconnection, burning and ageism. This is a particular interest of mine and ties in very closely with what I found in my PhD work. So the interpersonal theory of suicide posits that suicide may be the result of thwarted belongingness and perceived burdensomeness combined with an acquired capability for suicide. So this is a really relevant theory for COVID. So the pandemic contributes lockdown and physical distancing, which can increase that sense of disconnection in older adults. There's a loss of social opportunities. There's not explicitly talked about much, but the implied is the resource rationing that is increasing feelings of burden that an older person may already harbour about their worth to society, and feeling that in hearing these stories on the news about older people being selected out of particular interventions, whether that be intensive care or for treatment at those times when hospitals were overwhelmed, really reinforces that internalised ageism that many older people with depression and self-harm already harbour. Mental illness is important too. So the pandemic may be expected to produce more affective disorder. We know again through SARS that there was an increase in symptoms of depression and post-traumatic stress disorder, both during the epidemic and as a long-term consequence of the epidemic. Post-traumatic stress disorder during the SARS epidemic was prevalent, most prevalent in areas where SARS was very common compared to those areas where it wasn't. It was more prevalent in older people, even those that didn't have the infection. So many older people who have lived through a very recent epidemic where there was a very real threat, the new pandemic will be then adding to that pre-existing trauma, increasing suicide and mental illness, in parallel with what's already going on in general society with people having more anxiety, depression and fear in the general community. Access to treatment can also be expected to be adversely impacted by coronavirus, both for access to treatment for people who already have a mental illness and those who develop a mental illness during the pandemic. There's a number of studies now which suggest that people with mental illness may be more susceptible to COVID-19 and have more barriers to receiving medical care. Nursing home residents are especially at risk of neglect, particularly early in the pandemic when there were inadequate resources, staff were overwhelmed, and there was less community mental health team outreach or a shift in how that was delivered. And of course, through less family visits, which for many people, if they're lucky enough to have that, may have been their only meaningful social contact. Many mental health appointments were cancelled, and there was a question about who was providing scripts. Certainly in our area, we had GP practices that just shut down with no notice at all, and suddenly patients were scrambling to get scripts, have drug levels done for things like their lithium. So that became a fairly urgent thing to be sorted out. Many countries had disruption to public transport or they were suspended. And of course, many older people chose not to use public transport for fear of being infected when travelling to hospital appointments or outpatient clinics. And there's been much more of a focus on medical illness, that is coming down with coronavirus and having treatment for that, than mental illness. which might suggest to people with mental illness that their issues are not prioritised or not as important in presenting for healthcare. There's a question about what's been happening for emergency department presentations for people with suicidal behaviours, and that when the focus is on acute medical care, emergency care, there's overcrowding in EDs, long wait times, and prioritisation of COVID cases, quite rightly, given the risks of infection, that people who are presenting with suicidal behaviours may be sidelined, give up in terms of sitting in waiting rooms for long hours. And we can, extrapolate from that what that might mean in terms of outcomes for that group. I came across this paper very recently, I think it's only published a month or two ago by Brown. It's a really excellent summary of how people with dementia might be affected by COVID-19. It talks about disruptions to care and routines, increases in change behaviours or behavioural and psychological symptoms of dementia at a time when facilities are least equipped to manage that, and when efforts are really focused on reducing the spread of the virus. There's a suggestion that there's been an increase in psychotropic prescriptions in response to that loss of human contact and care, being overwhelmed or shuffled into infection control measures rather than the clinical care needs. And I guess we don't know that yet, but there's a suspicion that that might be occurring. Of course, people with dementia, particularly advanced dementia, may be fearful and misinterpret. Someone wearing a mask, someone dressed up in PPE may look quite frightening. And when they're coming at you in this big sort of hulky Yeti looking gown to deliver care, that you can imagine the range of responses someone with dementia might have and how they may misinterpret that situation in a fearful manner. The lack of physical closeness, we keep being told, don't touch people, don't shake hands, don't touch them. Keep washing, stay away 1.5 metres, which of course is going to result in, for some people, that loss of human contact and touch in greater loneliness and sadness. Again, risk factors for increasing anxiety and depression, both which in turn relate to suicide. Then there's the biorhythms and impact on physical health. People being kept in their rooms, not brought out into common areas, people living in the community, not being able to go outside, so there's less exercise, disrupted biorhythms, sleep-wake cycles, and really sets up a melting pot to predispose to delirium. So that lack of activity and mental stimulation, the changes in sleep, particularly reduction in sleep, can all lead to delirium, which has a pretty dreadful morbidity and mortality outcomes and can accelerate cognitive decline in people with dementia. And there's the impact on carers, and this is again something I think we haven't heard a lot about. Many services simply closed their books and said, look, we're not coming anymore when the pandemic started, leaving this huge burden of care on people caring for people with dementia at home, who would rely on services coming in each day to help get the person dressed and ready for the day or showered and organised, that now fell onto the carers. And there are also delays in packages being assigned to people with dementia, meaning that there's this sort of interim space where either people had to come into hospital or carers had to muddle on when they were really already overwhelmed. And of course, many carers share the same fears and worries as the general community about contracting the virus, and they themselves may have been unwell. And finally, access to acute care. The thought that if hospitals are swamped with COVID cases, what's going to happen in terms of resource allocation when a person with dementia needs acute care? Facilities all have advanced care planning as part of the criterion entry, that needs to be done and thought about, but many people living at home with dementia may not have made those plans and thought about those situations. And then, of course, there's the economic impact of the pandemic. It's widely reported that this is going to lead to a global recession, if not a depression. And we know that the Great Recession in Europe and North America in 2008 to 2010 was estimated to result in an additional 10,000 economic suicides. This is secondary to things like unemployment, being indebted, housing insecurity, which in turn, each of those things are associated with depression, anxiety and suicide. There's the financial insecurity in older adults as well, from things like the stock market collapse, lower interest rates, which many people may have been relying upon for their retirement savings and to live on. So putting some of those factors together, another excellent paper by Share summarises the various pathways to suicide. So those key initial elements, secondary to COVID, the uncertainty, social isolation, economic problems, interacting with vulnerable people, so people who may have already had a mental illness, who might have not much resilience, who live in areas where COVID is rampant, or who may have had direct experience of people dying or becoming very unwell from COVID. That in turn interacts with their pre-existing mental illness, with depression, anxiety, disorders rates going up, alcohol, substance use and other mental health conditions leading to suicide. We know that people who have had COVID have high rates of PTSD, especially those that have been through intensive care. That group particularly have fears around whether they've spread the illness to other people, issues of loss of income, of the stress of hospitalisation, and as we know from SARS, that increased risk of both PTSD and depression. And interestingly, COVID itself is associated with neurological symptoms in about a quarter of all people. And these can range from things to stroke, to ataxia, seizures and dizziness. So there's a number of different facets to think about. Okay, so now I'd like to move to talking about some international perspectives posing challenges for suicide prevention during the pandemic. So I've got to start in China and I've got to start in Wuhan, being where the virus is thought to have originated. So China already had high rates of old age suicide. That was pre-existing. There were inadequate social support services initially. Routine services were cancelled during the peak of the outbreak. Older adults couldn't actually receive or get to medical services for their chronic diseases because the hospitals cancelled these outpatient services. Public transport was suspended. General hospitals were quite overwhelmed. So all these barriers to treatment, you can see, would also raise anxiety in older people. Older people knew that there was a high case fatality rate. That is, if you're an older person, you're more likely to die if you contract the virus. There's very limited information. Most older adults in China receive their information from television and radio, and that information was quite out of date and inaccurate, leading to a lot of anxiety and misinformation about the pandemic. So if you were lucky enough to have a younger relative who was plugged into some other kind of media or information network, you might have been better informed. But for those that didn't, they were really relying on information that was unreliable. And of course, loneliness, the loss of family contact, of social opportunities outside of the home. There was a survey done in Wuhan very early this year, last couple of days of January, early February, looking at suicidal ideation in older people across the last 2 weeks. And the rates were quite high, lower than the 1 year prevalence, but quite high for just a 2-week period, with 10% of the Chinese elders endorsing suicidal ideation in the last 2 weeks. China then kicked into gear with strategies for prevention and reducing mental health crises, including suicidal behaviours. There were guidelines and public health educational materials put out for health professionals and the general public. There were new online mental health services, and mental health professionals were placed in isolation hospitals. Again, learning some lessons from SARS about those quarantine and isolation areas being particularly vulnerable. Community workers stepped into gear, and volunteers provided services, delivering groceries and medications to older adults. I note now that China had a period of having very few cases, and now they're just starting to get clusters in regions, but China is not completely locked down. Hong Kong had a particularly turbulent time of it. So for Hong Kong, coronavirus came at a time when there was dreadful political unrest, violence, and a shutdown in the economy. There were violent protests in the streets, which had started in June last year and really kept going until coronavirus hit. So people were already afraid to go out due to those violent protests on the streets, and there were already increased rates of depression and PTSD in Hong Kong. And remember, this comes on top of Hong Kong having survived SARS not that long ago. So again, PTSD, depression was already high, and suicide rates were higher. Interestingly, during SARS epidemic, it was older women that had a vastly increased rate of suicide. Not men, not younger people, older women. And this was thought to relate to the breakdown in social networks and limited access to medical care that occurred during SARS. Women were thought to be particularly vulnerable to those effects because they actually accessed those services and those social networks. So then combining that with the fact that many older people had lived through the SARS trauma, and this was now combined with a new threat. There were less services for older people in Hong Kong. There was a lack of community and family support to older people because of social distancing, and a reduction in daycare services. So older people were staying at home and not going to centres. There was a fear of contracting the virus, which led people actually to avoid going to appointments or leaving the house for clinic visits or seeing their doctors, meaning that both for people with pre-existing illness and those who developed mental illness during the pandemic, they weren't able to access mental health treatment. Italy was another hotspot in terms of the pandemic early on. And there's been lots of questions asked about why the virus appeared to be so virulent in Italy. Diego De Leo has written a separate paper, which is really worth a read, about the pandemic in Italy and how that affected suicide in older people. In Italy, there's a very close relationship between generations, where it's not at all unusual for children to see their elderly parents every day. Cultural practice, kissing, touching, hugging, handshakes and greetings, and the government was very slow to lock down. All these things are thought to have caught Italy unprepared in both terms of welfare and their health system. Infection rates were catastrophic in older people. So 36% of people over 70, 83% of deaths were for people in their 70s. So it was a very real thing that if you were an older person, you might get it and you'll probably die, which is a pretty frightening thought. Nursing homes were especially affected. There was a lack of PPE and social distancing. In one region in Lombardy in the north, 10% of nursing home residents died. This is an enormous number and far in excess of the expected number of deaths in nursing homes over the same period. And of course, along with these, the high mortality, there was tremendous grief. People were seeing military trucks carrying coffins to incinerators, often far from the person's home. There were no funerals, no possibility to be with the older person as they were dying. For many relatives, the last time they saw their older parent or other relative was when the ambulance came to pick them up to take them to hospital, and they didn't see them again. No opportunity to say goodbye. There were lots of media reports, of course, about the dire state of affairs in Italy, which of course would have increased anxiety and fear. And it's been raised that it may have even come to minds of older people to choose suicide over uncertain healthcare, particularly as they were hearing that older people were going to be sidelined in terms of treatment if they went to hospital. Italy then had a very strict lockdown and got on top of it, and the cases went right down. But I've seen recent reports describing the situation in Italy as a bit of a free-for-all. It's summer. They're now going through a second wave where people are coming back from their summer holidays in the Mediterranean mostly, Malta, Croatia, Greece, Spain, and bringing back COVID with them, which is thought to, of course, then lead to a second major outbreak in Italy. Schools in Italy have been closed since February and are due to reopen in September. So there's going to be new challenges emerging for the Italians. And of course, in Australia, we had the bushfires, the severe economic impact, cessation of tourism, lots of people, countless homes lost, town infrastructures lost, people's livelihoods lost. People aged 70 were targeted in government messages to stay home. There were changes in home care services to older people, and older people themselves were cancelling their services for fear of introducing infection into the household. There were reductions in family contact, like there has been around the world, with people being told to stay away from each other, increasing isolation. And we had suicide prevention organisations really stepping into gear. So Lifeline had an initial focus on the bushfires and then totally did an about-face to focus on support for people during the pandemic, using phone, text and chat media. Are You OK, another Australian organisation, had a lovely initiative of these things called connection cards, which were left on doorsteps by volunteers, and they had contact details for the volunteer who would express they were willing to listen or maybe to get groceries or provide other practical support. And these things would be expected to be particularly useful for older adults who are isolated. So I want to switch now to talking about solutions in terms of suicide prevention for older people during COVID-19. The broad headings I'm going to talk under are population-based approaches, ways of ensuring continuity of access to mental health care, measures to reduce loneliness and disconnection, and finally look at how we can minimise the adverse effects of quarantine. So you won't be able to read this slide, and that's fine, that's not the point. It's really just to stimulate me to remember to say I'm not covering everything and all risk factors here. Some of the things I particularly want to highlight are around domestic violence and elder abuse. So we've heard many reports now of increased rates of domestic violence during the pandemic. People who would usually be able to get away from the aggressors can't, and may be feeling entrapped and shut off from others and quite dependent on the perpetrators of violence. And public health responses need to respond to that. I have a good friend who's a GP who's working in a COVID clinic at the moment, and she was telling me that this clinic is meant to be for people with respiratory symptoms, and she assesses them, works out if they need a COVID test and then moves them along. But actually she's been inundated by people presenting with far more complex problems. Severe domestic violence, untreated mental illness, things that these clinics are not really equipped to deal with, and initially didn't have the resources to know what to do with people presenting in these complex situations. We've also all heard reports of alcohol consumption increasing. We know that alcohol use is a particular risk factor for suicide, both in older adults and younger. And we're hearing about it, but not so much about the safe drinking messages. And of course, access to means is always important in any kind of suicide prevention discussion. In the US, gun shops were reporting that there was a huge rate and increase in purchase of firearms. Thankfully, we don't have that problem here, but we do have access to medications which can be taken in overdose. And there needs to be some thought given to how we restrict access to means, here being the number of medications or absolute number of tablets that people might be able to access to prevent those impulsive suicides. In terms of primary prevention, that is population-based approaches, I'd recommend you have a look at the Australian Psychological Society's guidelines that they put out. It's a really lovely document which talks about some very general principles which we can impart to older people that we're working with. So it talks about seeking information from reliable sources and in moderation. So the constant scrolling through social media or trawling through one news channel after another, really unhelpful. Teaching people how to moderate their exposure. Providing information about why isolation is important and general education about the virus to reduce fear from misinformation and lack of knowledge. There's also suggested skills for keeping concerns in perspective and using healthy coping strategies. Suggestions for coping with social distancing, such as video conferencing, text messages, phone calls, emails with family and friends. And using online technologies to maintain a sense of belonging and reduce isolation. Again, key risk factors for suicide prevention. You can see this nursing home resident has used a simple whiteboard to send a personalised message to her family. But we know that older adults in Australia, that is those over 65, are particularly digitally disadvantaged. So it's all well and good to tell people to go and use online technologies. And I was talking to Stephen about this before we started, but I see many people at home who don't even have a telephone. So we need to make sure that we're suggesting things which are realistic. And if people do have access to those technologies, that they know how to use them, that they know that they have the skills to access. There's also some resources for older adults online. So Lifeline has a great resource, Beyond Blue has good stuff. The Aging Futures Institute at UNSW has this particular interface where you can click on a different part of the wheel down below to get more information. So for example, if you click on the bit that says emotional wellness, you hear about strategies to limit exposure to the media, about suggestions to engage in your creative side, meditation, mindfulness, to reduce stress and accept the situation, the importance of sticking to a routine, options to talk to a psychologist, and links to other resources and websites that might be helpful. If you click on the social wellness tab, there's some tips about what to do if you don't own a computer, which seems very relevant because most of the things being promoted are video conference based, which many older adults do not have access to. Talks about going old school, writing letters, leaving a note at someone's door, ringing someone. And there's also a national COVID older persons information hotline. Bit of a mouthful, but specifically designed for older people feeling lonely or distressed by coronavirus. The Dementia Australia has also launched an online chat to help people with dementia navigate what to do if services are closing or pulling out. So the next thing was around continuity of access to mental health care. So community older persons mental teams have a major role here, but of course the majority of people are going to be seen in primary care. So that is in general practice. For us in older persons mental health, all our care coordinators or case managers going through patient lists and screening for and identifying those people that we think might be particularly vulnerable to either exacerbations of mental illness or relapse and suicide. So for example, those who live alone, who were already socially isolated, who might have chronic medical comorbidities, who might be functionally impaired or are currently unwell, and following up those very actively who may be at risk of relapse during this time. And instituting regular welfare checks and enhanced follow-up. So our case managers have been ringing people who they think are particularly vulnerable once a week. Do you have toilet paper? Have you got food? Have you got enough medication? And helping link them into various services that can answer those questions if they are lacking in those areas. In our area, many GPs just shut up shop and when we were ringing patients to check in with them and suggesting if they were sick to go and see their GP, they were saying, well, my GP is closed. There's a sign on the door. They're not there anymore. And so we suddenly had to work out how to manage people who may have been receiving depot antipsychotics from their GP, or who were on lithium and needed blood levels done, or other medication monitoring. And so that had to be negotiated as to who was going to take over doing those roles, whether that be in aged care in general, or whether that was to come to mental health. There were needs that were no longer being met by primary care that had to be scooped up. And of course, for mental health patients with COVID-19, there's a particular group that needed to be actively followed up. In our own service, we haven't actually had anyone in that category, but certainly other services have. And our geriatrician colleagues are following up people both in the police hotels, the quarantine, returned travellers, but also in the community with COVID. Another way of ensuring continued access to mental health care was through a real boom in telehealth services. Early on, there was very rigorous discussions about what new item numbers were needed to make sure that people could access mental health care through the MBS. There was increased capacity in the mental health triage and access line. So in our own area, the workforce was massively increased. There was a doubling of phone calls from older adults and also from people under 18, and a massive increase in adults between the age of 18 to 65. So there was a need for extra staff to man those hotlines to take those calls. We know that there are some established online psychotherapies for anxiety and depression with a good evidence base. In fact, CRUFAD, through the This Way Up website, was providing free psychotherapy online for those disorders early in the pandemic. There's also good online psychotherapy which has been validated for loneliness. However, telehealth for suicidal ideation is relatively less developed. And of course, grief counselling can also be provided via telephone and via telemedicine. There are a number of ways of reducing loneliness and disconnection in older adults, two key risk factors for suicide. So the Kindness Pandemic, this is a grassroots initiative by Celebrate Ageing to promote acts of intergenerational kindness. Children are encouraged to keep in touch with their older parents. There's a new initiative called the Being Supported Mental Health Peer Support Line. So this is brand new. It's a peer-run support line which operates 7 days a week. It's run by mental health peer workers in New South Wales, and it's the first of its kind. So it's a 6-month pilot program which is happening now, supported by the Mental Health Commission of New South Wales and the New South Wales Government. And it provides supportive, reassuring, non-crisis assistance over the phone and in online platforms. Telephone crisis lines are also increasing in their resourcing. Initially, DeLeo and others developed a service called the Telehelp Telecheck, which was a telephone support and monitoring service targeting older adults in Padua in Italy, and has demonstrated benefits for reducing suicide rates in older adults, particularly women in that region. So this is a proactive phone contact with older adults. It can be used to provide assistance to older people at risk of suicide through social isolation or through psychological or physical illness. And there's a suggestion that it could be expanded to be delivered by families and friends and charities and voluntary organisations, not just dedicated health services. Crisis lines like Beyond Blue, Lifeline represent an inexpensive, convenient and anonymous way of people seeking emergency support too. There are some local initiatives. So Jane Massa, who is our coordinator for suicide and depression prevention, in older persons' mental health in Sydney Local Health District. One of her initiatives was set up with the Inner West Council to develop conversation groups which allow older people to meet over the phone, to learn about each other, talk about what matters to them, and conversations, practicing mindful meditation and other wellbeing activities. There are specific groups that are running during the pandemic too, such as this one, jewellery making for Aboriginal and Torres Strait Islander people, the 2x2 walking companion, the collage club with an artist, and a project called Makerspace, particularly designed to keep men connected during the pandemic, older men. Swinburne's Wellbeing Clinic for Older Adults is now operating at a national level. It's been going for 10 years as a face-to-face clinic, providing counselling and support to people living in residential aged care facilities, but it's now become a free national telehealth counselling and support service. It's free, it's available for both residents of aged care facilities, but also to staff and family members of people who are living in aged care facilities. They can provide telephone or video-based counselling to help with emotional support and to help address problems, worries or stress. It's not a crisis service though, and so it's not designed for emergencies, but part of the beauty of it is that access is really easy. You don't need a GP referral or an allied health referral. There's an online referral form and you can get the service quite easily. So finally, to the last point, which was about how do we reduce the adverse effects of quarantine, was certainly public education. We learnt from the experience of SARS that people need to understand why they're being put in quarantine or why they're told to isolate. And we know also that the longer the quarantine goes for, the more adverse effects there are in terms of mental health. So making sure that that period is the minimum duration that's needed. Ensuring that older people have access to food, household essentials and medicine. And looking at home-based activities to prevent boredom while in quarantine. So this photo at the bottom here is of the lady known as the literacy granny in Kerala in India. So she wrote a letter in the local newspaper to thank people who stayed in quarantine during the initial stages of the pandemic, to thank them for staying in quarantine, essentially to keep others safe. This lady shot to fame 2 years ago when she enrolled in the Kerala State Literacy Program to learn how to read and write at the age of 96. So pretty fabulous story. Okay, so in conclusion, COVID-19 will have an impact on the risk factors for suicide in older adults, and these are quite predictable. Particular measures which result from the pandemic, which increase isolation and reduce access to care, are especially relevant. Each country and region is going to have its own unique socio-political context, which adds complexity, compounds risk, and needs local solutions to address their particular risk factors. But there are certainly core elements of prevention applicable internationally. So providing older people with accurate, accessible information, promoting self-help and positive coping, reducing isolation through technology and creativity, as well as telehealth, and maintaining access to mental health services for older adults, both those who already have pre-existing mental illness and those who might be vulnerable to developing anxiety and depression and suicidal thinking during the pandemic. So this is going to need some proactive screening. Okay, thank you very much. I will stop sharing so I can let Judy take over.
We don't seem to have any questions at the moment. People were just asking whether your presentation would be available. Yes, we will be sending that out with the certificates in about a week, week and a half, if that's all right. And also with the recording will be available on the World Health Network website in about 2 or 3 weeks' time. So if you have any questions, if you could just fill in the Q&A now and we'll be happy to answer you. Here we go. No, that's about all I think we have at the moment.
Sorry about my use of acronyms. I can just see on the chat.
That's okay. There's one now. I've contacted a number of NH to offer psychological support, but have received no replies. How do you get in?
Wow, really? Offering psychological support to residential care and people not taking up that service. Okay. That's very interesting. So I'm wondering if you mean quite literally or metaphorically. It is extremely hard to get into a nursing home at the moment. I'm screened within an inch of my life, like today when I was at a nursing home in Annandale. So they are obviously limiting visitors. I can see residents being visited by family members who sit outside the fence a few metres away in order to see their relatives. But healthcare professionals can get in. If you've had your flu jab, if you are willing to provide phone services, then yes, it should be very possible to deliver those services. So I'm surprised that no one's taken you up on that.
Another question, is there a plan like this being implemented for people in Melbourne?
I don't have direct knowledge of what's happening in Melbourne. I guess the principles I'm talking about today really extrapolate what we know about self-harm and suicide in older adults already, and then just combine that with the social milieu that we have now and how the two may interrelate. There are some, great minds in Melbourne in terms of suicide prevention who I'm sure are influencing that state's response in terms of mental health. Certainly that nursing home resident support line came from Swinburne in Victoria. The same MBS items for telehealth, they're available nationally, so those things would be available. But for those particular nursing homes that have high numbers of COVID cases, I'd be very interested to know what's actually happening there. Is there actually any proactive screening or mental health in reach into those facilities where there must be huge terror at the prospect of facing death of either yourself or fellow residents and friends in care, both for people living it and for their relatives and the staff.
And are you able to say the name of that Italian article on COVID?
Yeah, so it's on the IPA website. So that same website I introduced at the beginning, International Psychogeriatrics Association. If you put that in to search bar, and I think even a little box at the top comes up COVID articles, and it's in that huge list. The Italian experience is in there. I don't know the exact name of the article, but if you look up that website, there's a whole list of special articles written focusing on older people during the pandemic. Diego De Leo and Mario Trabuzzi, I think, are the two authors.
And what are your thoughts about reducing isolation and increasing activities? There are challenges with older people with sensory impairment.
Yeah, that's a really good point. And I think particularly in residential aged care, we rely on sort of group activities to get the maximum reach to the most number of people and be time and cost effective for the person who's delivering the activity. In my clinical work recently, all those things have stopped. There are no group activities in the nursing homes I've been visiting, and boredom, despondency, demoralisation are really very high. So, I mean, at a micro level, I guess we're working with individuals about looking at what their particular interests are, what things are accessible, and how can we facilitate access to those activities. But that's only going to reach a very small proportion. Doing some work with the New South Wales Health, with the older persons division, I've forgotten the proper name for it, I'm sorry, and talking with Dr. Kate Jackson about what we can do in terms of reducing isolation at a much bigger level. And nursing homes are certainly a focus there. People who have relatives that can stay in touch, or who live with a spouse, or who already live with one of their children or something like that, they're of course are in a much better position in terms of addressing loneliness, boredom and inactivity. But it's really something that needs a much broader sort of primary prevention approach.
Great. Is there any data on the impact for older aged care staff?
Not that I'm aware of, but I'd imagine it's coming. And I think certainly places like Italy and Victoria, where COVID cases are predominantly in older adults and nursing homes have been disproportionately affected, you would expect that staff working in those facilities would have very high rates of mental health symptoms, if not illness. Extremely stressful working environment. And of course, that's just being in that climate where you know people have the infection, where you're wanting not to spread it to others, knowing that many will die if they contract the virus. But also fear of bringing the virus home to your loved ones, you know, just like that experience of the COVID ICU nurse in Italy, or the ED director, that fear of bringing it home, you know, going to do your job, but then bringing the risk back with you. I think that's a really important aspect of the pandemic that we don't know enough about yet, but can anticipate is an area of need.
What ways can carers of older people who are stressed be supported?
So support for carers, so the Dementia Australia website has good information for carers, and there are online ways of carers being connected with other carers. Carers, of course, are always encouraged to look after their own mental and physical health. It's going to be practically more difficult to get breaks or in-home respite, whether that's formal or informal at the moment. But those same principles that we know help carers in general, let alone in a pandemic, should be promoted.
Okay, I don't have any more questions at the moment.
Thank you, Anne. We'll see if more questions come up, but I'll fill the space for a moment or two. There is in terms of self-care, there is a webinar coming up through MHPN, the 2nd of September, treating a health professional with mental health issues, which speaks to that last question. They say registrations are closing. It'll be highlighting the importance of health professionals taking care of their mental health and seeking appropriate professional care when needed. So if this, as they always say on the television, if this presentation brings up any issues for you, that might be a webinar worth looking at. So I think anyone who's registered for this probably would have got that email, but it's so easy to miss emails. In this area, one of the organisations, or one of the models for care that's being trialled, is the Compassionate Communities model of care, which is an international public health approach to isolation that's had very good results in the UK, and that's peer-reviewed article from a town called Frome in southwest England that focused pretty much through the compassionate community public health model. It reduced hospital admissions by about 25%, particularly obviously in older people. So that's worth thinking about. And Michelle and Craig, maybe that's something we could think about for our next meeting, is looking into the issue of social isolation and the social effects. But on the Q&A or the chat room, this is the usual time that we start to think about our next meeting. So if there are any thoughts to what you would like, it's a democratic group of people, so you can certainly put in your thoughts for what you might find you'd like to hear of in our next meeting, which will be October the 14th. And obviously you'll get full notification of that. You're going to have a look in the Q&A or chat. Judy, are there any more questions?
I've got one more question.
Great.
Can we share this with our community on Facebook to get the info out there to more people in the community?
Yeah, look, it's obviously written for an audience that has some health background. So I think it would probably need a little bit of reworking to be properly accessible to the general community. Yeah. But certainly I think participants will have access to the PDF of this talk.
No more questions.
Well, Anne, you really have illustrated so well this challenge for older people in our community at this COVID time. Of course, social isolation and distress amongst the elderly has been a public health challenge for a long time, but this challenge on top of it really is distressing, intensely distressing. And as you said, we'll have to wait to see what's going to happen. You wisely, I think, stayed out of the economic versus public health debate. But that, I think, also is a distress. I think you touched on it. That's also very distressing for the elderly to see this hierarchy of who should be cared for.
Yeah, we touch on that a little bit in the MJA piece. It is very controversial, but it's coming up, and people will be thinking about it and reflecting on what does that mean for me? What is my value to society?
No, I think
horrific things that have been said by politicians overseas in relation to that. Yes,
I think we've been quite lucky in Australia and New Zealand in that respect, but it's an important issue to think of. So perhaps if there's no more questions, Judy, I'd like to also thank Amanda Oskiak, the project officer from MHPN, for all of the work she's put into organising tonight's meeting, and to thank all our, I think, 55 participants for signing on tonight. And Anne, of course, that was a wonderful presentation. I thank you very much for it. So October the 14th is the next meeting, and everyone take care and see you in October. Thank you.